A few minutes ago, I had a very, very short conversation with Dr. Thompson, and I was reminded of what the healthcare community means to Westchester. And when you push yourself away from the table a little bit and you say to yourself, what's happened here in the last couple of years, we now have 50,000 employees in terms of healthcare and life sciences. We have a $15 billion industry in healthcare. We have an enormous infrastructure that supports it that we didn't have several years ago, and probably capital investments that we estimate of over a few $1 billion. So what the healthcare community has done for our community overall has been nothing less than sensational. So I thank you from the bottom of the business heart and all that. And now, if you don't mind, I will introduce our guest speaker. It is now my distinct honor to introduce the Luncheon keynote speaker for this year's Healthcare Tech Conference. And I would like to thank the generous Luncheon keynote sponsor, Greater New York Hospital Association Ventures. Dr. Craig Thompson is one of the great stars in the healthcare and scientific universe. Dr. Thompson became president and chief executive officer of Memorial Sloan Kettering Cancer Center in 2010. Before that, he worked for the University of Pennsylvania, first as a professor and scientific director, then as director of the university's Abramson Cancer Center and associate vice president for cancer services of the University of Pennsylvania healthcare system. Sloan Kettering is the world's oldest and largest private institution devoted to one disease, and that is cancer, and its prevention, treatment, research, and education. And as he often has said publicly and privately, cancer is just not one disease. It is really as many as 400 diseases. Under his leadership, Sloan is incorporating precision medicine and immuno-oncology and combining them with traditional forms of cancer therapy, including radiation and chemotherapy. Today's cancer patient wants therapies to be more accessible. Once the initial scare of the diagnosis is over and they begin their treatment plan, patients don't want to be in a complicated hospital setting. They want to be in a treatment setting that is more conducive to their lives, treatment that will enable them to continue their jobs and take care of their families. That's when specialty hospitals like Sloan Kettering and community hospitals coexist or collaborate, which is the subject of today's talk. Ladies and gentlemen, please welcome Dr. Craig Thompson.
Thank you, Bill. We have to get a picture, apparently.
Okay.
Well, thank you, Bill, although I think you gave the major points that I wanted to get across to the audience already in the introduction. It's a daunting task to speak to this group because we have representatives from the healthcare leaders of this community that Bill just articulated, how important it is to Westchester County. And so they know a lot about healthcare delivery, and it's been a model that's been changing dramatically, and Westchester has been a center point of that, of the really 4 amazing accountable care organizations and the other existing medical centers here in Westchester provide extraordinarily good care to citizens of Westchester. And I think that is actually a business driver. So we also have the business leaders here that are part of the association. And so I'm cognizant that I have to speak to that as well. And so my real role here today, while you're eating lunch or finishing your desserts, is to really start to dispel some of the misconceptions about what cancer care is about and all this stuff you're reading about in the newspaper, this explosion of new techniques to treat cancer, and at the same time, really talk about the future and what's possible and what we feel as a caregiver here in Westchester County is important for us to be here and what we do in partnership, in fact, with the other great healthcare accountable care organizations that are here. So first of all, when I accepted this invitation, it was, well, you're new to Westchester County. Well, we're not actually new. We've been here for 23 years. Memorial Sloan Kettering has had a major outpatient center for 23 years here in Westchester County. We have been one of the largest, for a lot of that time, the largest oncology providers. Now, every one of the hospitals represented here has a great oncology department. So when Northwell took over our partner hospital, which was Phelps, we had an outpatient facility on the Phelps campus since 1994. Keith Sapien's here. We were just reminiscing on that great partnership. When Northwell took over the hospital and asked us to leave, to be honest, they asked us to leave, we decided we should stay and continue to provide the care that we provide and have provided to the Westchester community. And what was to build a freestanding facility that exists, and it's in West Harrison. Now, I'm reminded every time I come to a Westchester meeting that no one in Westchester knows where West Harrison is. It's west of Harrison, okay? But actually, the only reason we actually keep saying this, and it is a joke, so you all laughed, is that we, like everyone else, thought it was in the town of Harrison. And so a good center point right off of 287 to actually continue to provide care and opportunities to patients in Westchester. And then we realized that everybody, when we opened the facility, would plug into their navigator system in their car or on their phone or Google Earth and say, I'd like to go there. There is no such place because our address is in West Harrison and you can't change that. So we just heard about telemedicine. It is changing everything. One thing it changed is we're in West Harrison. It's a very complicated time for healthcare, and that's one of the reasons why we're hearing some of the advances in telemedicine. We're hearing about these new crises of opioids that we covered this morning. We heard about how we partnered together in associations with the morning keynote. And so one of the things that's antithetical to everything we're hearing out of Washington, we're hearing out from Albany, is how is it that we have a freestanding specialty hospital? And then the second comment I get, particularly from business leaders and from patients who are concerned about it, is why is there a freestanding cancer hospital? And as Bill just said, we're the oldest cancer hospital in America. We're the largest private cancer hospital in America. How can you keep going on if for 133 years you haven't solved this problem? And so I'm going to start with that as sort of the first point, because it's the first thing any patient, any family, any business group, and quite honestly, other healthcare leaders ask us, which is, if you, as good as you claim to be, want to be, aspire to be, this is our fundamental question. Why haven't we cured cancer? So one part of this is I am going to try and give some examples to the healthcare community. I'm going to try and give some examples to the business community. But what I want to do is actually take you back to what you understand about cancer. We've had an explosion in the improvement of the care of cardiovascular disease. When I went into medicine in the mid-1970s and did my internship, the #1 killer, by far and away over everything else, of people in their working years for the business leaders, between 35 and 65, was cardiovascular disease. Everybody knows, if you think about in your parents' generation, that key person in your life that died because they went to work, had a heart attack, and didn't come home. That doesn't really happen very often. In fact, we think it's extraordinarily rare. 75% reduction in mortality from cardiovascular diseases in the workforce between 35 to 65. Remarkable. But what's changed is now the #1 cause of death and hospitalization for Americans between 35 and 65 is cancer. The second most common cause is still cardiovascular disease, but it's a distant second. And the third is what we talked about earlier today, which was narcotic addiction and accidents combined, because there's this growing idea that a lot of the accidents we're seeing are perpetuated by this addiction philosophy, and that was covered this morning. So cancer is a really scary disease for the people in your company, for the patients you care for. It's what Americans fear most for the health of themselves or their family. The reality is, in our lifetimes, 50% of males will get a diagnosis of cancer. And now we've just turned the corner for women catching up with men in every aspect of life. We used to say it was a third of women. This year it passes 40%. 40% of women will get cancer. So again, why haven't we cured cancer? Well, we have. We've cured a large number of cancers, and unfortunately, cancer is a much more complex disease than when we started off. So Bill said, which is something we say all the time, there are over 400 different types of cancer in human beings, and every one of them requires a different treatment and a different set of expertises. So let me back that statement up in a very quick way. So this is something I stole a few years ago. It's from the National Cancer Institute, and it's to look at, so this is just women. There's an equivalent one for males, but we're not going to bother to go over that. We're just going to talk about the women one. And what you can see here is this is just over 73 years of data. So it takes a while to figure out how well people do in the Federal Registry. So this is actually compiled to the last time they had a full update, which was 2004. And I'm going to talk a little bit about what's happened since 2004. In 1930, the leading cause of cancer death in America, no one here would have guessed. The leading cause is the number 2 on this. It's gastric cancer. If you look and start in 1930, it's that second curve down there that's in sort of the turquoise color. That's stomach cancer. It has plummeted since 1930. Today, it's extraordinarily rare to see someone with gastric cancer. And when they do, it's almost always associated with one of 2 infections. And so the treatment has to be tailored to that new information that we just got out of sequencing the genomes of the remaining patients with gastric cancer. It's an association with ulcer disease and caused by a bacteria called Helicobacter pylori, or it's caused by Epstein-Barr virus at the gastric esophageal junction. It's our job at Memorial Sloan Kettering to get that insight. Why is there still 5,000 cases in America? But what's more extraordinary is how did we get to the point where it was the leading cause of death, because it was equal in males and females, to 0? And nobody probably has an idea about why 1930 was pivotal to that. Anybody got an idea? Anyone want to shout it out? 1930 was the first year you could buy a refrigerator for your house. By 1938, they were mass-produced and everybody could use them. And food preservation changed from the curing of meats with nitrates or smoke to being able to be safely preserved the way we do and get food out of a refrigerator. And removing those carcinogens from our diet led to a dramatic alteration. So the gastric cancer is extraordinarily rare now. And actually, we have a chance, because the remaining ones are infection-associated, to actually eliminate gastric cancer. Second, it's actually the leading one for women, but guys don't get uterine and cervical cancer. The leading cause of death back then was cervical cancer for women. It's lumped in the way the federal government does statistics into uterine and cervical, because the cervix is actually part of the uterus. And it was a major cause of death. In the third world, it remains the leading cause of death for women from cancer. But in our country, and you can see there's an inflection point. It went down a little bit as surgeons learned how to do hysterectomies. But it really took a dive starting in 1948 to 1950. That's when the Pap test, that's what George Papanicolaou reduced as a research test, the Pap test. But the dramatic change that should come in our kids' generation is that we now understand from the work that started with George Papanicolaou that, in fact, virtually all cervical cancer is caused by a virus, by HPV. And there is now a very effective, as of last year, there's a vaccine against every major oncogenic type. That means the virus subtypes that cause cancer for the American population. And we know that this is part of the growing spread of head and neck cancer, because unfortunately our president told us a number of years ago that oral sex didn't count. And the HPV has spread, unfortunately, whether you like it or not, by a sexually transmitted means, and it affects oral cancers and it affects urogenital cancers. And boys are the fastest rising group of population who is getting HPV-associated cancers. And yet we can vaccinate kids before they're ever exposed and completely eliminate the risk. Australia is way ahead of it. They mandated a number of years nationally, and they're seeing an absolute decline now as the next generation is coming on. It's actually in the head and neck cancers because they occur earlier for reasons we don't understand than the cervical cancers. But in the US, we still are bothered by the fact that this is sexually transmitted, so we couldn't help kids, you can think about it. But extraordinary accomplishments. Those two diseases will be wiped out, and they were the leading cause of death from cancer just 80 years ago. But we are seeing some big dramatic change. So one's gone up dramatically. It's another place where women have caught up. And really, the inflection point is when the year Virginia Slims came out, for those of us that are, if we remember, and women caught up with smoking. With guys, it was already up there. That's why I didn't want to do it. But women didn't start in population smoking. But today, the #1 demographic of women at risk for lung cancer in Westchester is the young professional woman who's still smoking. She's trying to get up in your company's ranks between the ages of 35 and 40 and still smoking because it relieves some stress and says, I can quit later. We still need a ways to go on smoking. It's going to take, even if everybody stopped smoking today, that cause of death, which is leading for women and for men for lung cancer, will take 15 years to get out of the population because the risk lasts for that next 15 years after you stop smoking. So programs of tobacco cessation for the business leaders really make a difference. And you can get them at every one of the major medical centers. We're proud to have helped provide some of the epidemiologic evidence that allows you to say that and definitively be able to do that and be able to do some of the screening things. The big inflection point came when we didn't just throw chemotherapy, the horrible toxic medicines that kill proliferating cells, and started to have rational discoveries of ways to specifically treat individual cancers, not just give toxic chemotherapy or radiation to everybody. And the inflection point for that, for the community and our healthcare givers here, actually was 1990, and that's why I drew a line there between 1990. Since that day, we've had a 1% decrease per year in the mortality from all forms of cancer for the US population. It's not mirrored anywhere else in the world because we are the best at being out front in innovation in healthcare. So we're just beginning to see that inflection point. I think in England, they're saying it's somewhere in the mid-2000s. They're seeing that inflection point because they're about 10 years behind us in adopting new innovations. But since 1990, we've seen a 1% decline virtually every year. So the mortality from cancer has decreased over 20% in the last generation and since 1990. And that's phenomenal. So today, patients that we see at Memorial Sloan Kettering, 70% or more of them are alive and well, taking care of their families, executing their job, living a fulfilling life 5 years after a cancer diagnosis. But we still have a long ways to go. We're not where cardiovascular disease is right now. We still don't know all the causes of cancer. In fact, it wasn't until 2003, which is why I use this as the slide, that the next revolution in cancer care came, which was to understand the molecular basis of these 400 different types of cancer. And that came as an unexpected benefit of sequencing the human genome, which was biology's moonshot, if you will. That the NIH starting in 1993, to sequence one person's genome for $3 billion. And we thought it would give us insights to all diseases. Unfortunately, it didn't, but it gave us a template of what a human being looks like to which we can compare everyone else. And we learned some pretty dramatic facts. And the first thing we learned, unequivocally, we sort of knew it, but now it's absolute, so you can put it in big, bold letters. Despite everything you've heard, cancer is not a hereditable or genetic disease. It's not an inherited disease. And I'm going to reinforce that already. Yes, there are a few unfortunate individuals that inherit a few rare mutations that exist that mom and dad can give you. There are BRCA1 and BRCA2 that everybody's heard for breast cancer. That is less than 5% of all breast cancers in the country, okay? And it is this thing that is called Lynch syndrome, or mismatch repair syndrome for the physicians in the world, which causes DNA to not be copied faithfully in all the cells in our body and increases the risk of cancer. But that is less than 5% of the people that get cancer. And we know that because when you know what somebody's genome is, you can know what they inherited from mom and what they inherited from dad. And then, which is something we have been pioneering at Memorial Sloan Kettering, We spend our own money, $22 million every year, to sequence the DNA from the tumor of every patient that we collect a tumor sample to get a diagnosis from. At the same time, we sequence their DNA of the tumor, as well as the DNA that they inherited from mom and dad by taking a biopsy from normal tissue. And the one thing we know is all the things that cause cancer are mutations that exist in the tumor's DNA that you did not inherit from mom and dad. It is in the DNA of that tumor, which means it arose, as we said for the healthcare professionals, somatically, with you as an individual. It arose uniquely in you. You didn't inherit it from mom and dad. You can, if you get cancer, go blame your mom and dad, except in the rare instances of, as I said, BRCA1 or BRCA2. But it's real to you, and every cell carries that mutation, and that's what drives that tumor to continue to proliferate out of excess of the normal cells and damage the normal cells and ultimately acquire to the place the ability to metastasize and damage people elsewhere. And we know that really equivalently. We just reported the first, so remember, the first genome was sequenced for $3 billion in 2003 was the completion. It took 10 years. Today, we can sequence a genome in less than a week, and we can do it for about $700. Okay? We don't do the whole sequencing, I will be honest. We've reduced that to a panel of the 600 genes that are commonly, we have about 20,000 genes, just for the business leaders to understand. We're made up of 20,000 different genes. Only about 600 of them, as best we can tell, go wrong in cancer, but 600 can go wrong. And so we do, for every patient that needs a treatment decision at Memorial Sloan Kettering, spend our own money and philanthropy that we raise from the greater New York community to sequence every one of those 10,000 people we take care of each year. And this is last year's cohort, which we just reported on in the literature to share with every other hospital. And it's a publicly available database. It's actually being incorporated to the NCI so that they can make it available to every center in the world. But more importantly, the first people that benefit from this information are our patients. And they're equally available whether you see us in our clinics here in Westchester or you see us downtown in New York. And that allows us to make a lot of conclusions that unfortunately don't help patients in this generation, but allow us to understand where we can deploy the new therapies that we're going to briefly talk about in just a second in therapy. So we can do this in less than a week from when we see a patient and get the initial biopsy to unfortunately have to tell a patient and their family they have cancer. We can find out what personally went wrong. Not that you have lung cancer, but you have lung cancer with this specific mutation, and it's available, if there's a drug available that can treat that specific mutation, we don't have to give you toxic cytochemotherapy. We can give you what's called a targeted therapy or a precision medicine therapy, which you've been hearing about in the literature. And that launches our program in precision medicine. We have over 800 clinical trials available to patients. The vast majority are based in these new precision medicine treatments to match the mutation that a patient, an individual mutation of a patient's lung cancer or breast cancer or colon cancer, to their specific therapy. And to prove that, we've got about 10 or 15 examples that have now gone into common practice as a result of that exercise. The first was Gleevec, which you may have heard of about 10 years ago that our scientist Charles Sawyer's reduced to practice. That's available at every hospital represented in this room today. You can buy it as a medicine. But the current new 60 shots on goal, as we say, or the new therapies like that, are only available in clinical trials. So I have one aside to the business leaders. Many of your executives that are in your C-suite come to us, and I often have to talk to them because they won't be convinced by the doctor. Somehow they think some CEO. I am a medical oncologist, but we have much better medical oncologists at Memorial Sloan Kettering than me, 1,200 of them, in fact. But we're expert in each of these 400 diseases. And they constantly say, I don't want to be in a trial. Give me the one that's better. That's not the way it works in any form of medicine, so the other healthcare centers can back me up on this. We give every patient the standard of care, the best proven therapy to give them the optimum chance to turn cancer either into a curable or a chronic illness that has been established by the entire national community of taking care of cancer patients. And then we write a clinical trial that says, but if we added this additional technique, this additional therapy, precision medicine, could we improve it? And the only way to be sure about that is, unfortunately, to do these things called randomized trials, where some patients just get the standard of care, which is the best they'd be offered anywhere else, or they get the standard of care plus a new medicine. This has become a national controversy. You'll hear about it from the medical center. It's not fair that you're a guinea pig. That's why actually the C-suite of your businesses comes to me. I don't want to be a guinea pig. Here's what you can take back to your workforce. You're going to get the standard of care if you enter into clinical trial. People will really pay attention to make sure it's delivered on time, on safe, in the most effective way. But in addition, you get a chance to be on a new medicine. A couple of years ago, we were part of a clinical trial. We led a clinical trial for one of the amazing new therapies for prostate cancer, for advanced prostate cancer. And it was absolutely transforming. And every single patient that went on the trial was benefited. It was one of these new precision medicines that you've heard about. I'm not going to name it, but it was for prostate cancer. And I got a call from the New York Times. Again, they also like to call the CEO. I don't know why. And say, how can you consciously run a clinical trial where what we hear is every patient's benefited? How can you have a control arm? How is that right? Those people didn't, they're guinea pigs. And I said, no, you don't understand what modern clinical trials. So I'm telling you, this is an anecdote so that you can take it back. Every trial we do essentially is designed now. So the first group of people that get a therapy, once we know unequivocally it works, it improves care, are the control people in that clinical trial. We make every drug company, every provider, make sure as part of our deal to do the clinical trial that it will be made immediately available the minute we know there's a clinical benefit to the patients who are on that trial, and they immediately get it. So with the day that New York Times reporter called me, I said, no, every single patient in the trial is on that medicine right now. We did that 3 months ago. You're out of date. And trust me, no one in that trial was upset because there was no other way for another year to ever get that medicine because it hadn't been approved by the FDA yet. And so that's one of the things we really provide to the community. There are cancers where there isn't going to be an optimum outcome for a patient and their family in absent a clinical trial or some new innovation. At our site here in Westchester, we have over 300 clinical trials available. 60 involve medicines that are in the new precision medicine sphere that are not available anywhere else. We absolutely agree with the other medical centers here that there's terrific oncologists, many of them trained with us. We just heard about one. They got an award in part of our research mission. And we're thrilled to be part of that. And so there's real high quality care for a lot of cancer patients. If their disease is caught early enough, their primary doctor is right. You're going to get a great care at your own medical center. But we provide that second opinion to the community to give confidence that whatever you get is right. And we offer hope in the popularity of these clinical trials. The average hospital in America puts 3% of their cancer patients on a clinical trial. It's the only way to get the newest and most innovative stuff that's going on. We think 70% of patients probably don't need to be on a clinical trial. We've gotten good enough at certain forms of cancer, certain common forms of cancer. But we believe the other third ought to all be a clinical trial. And today at Memorial, 32% of our patients are on clinical trials. It doesn't matter where you receive care from us, whether it's here in Westchester, or it's in New Jersey, or it's down on our main campus in Manhattan. So that's about this whole idea about the genetics. Second, this is really for the business leaders. One of the things you'll learn by doing all that sequencing, and we share our database with various epidemiologists that work in the federal government, you start to understand, this reinforced the idea that cancer is not a genetic disease. I don't have a pointer, but if you look in the middle of the left hand, there is the genetic causes of cancer, and it's about 5%. Cancer is an environmental disease. That's why gastric cancer went down so much when we stopped smoking and curing meats. It's caused by environmental exposures and carcinogen. Everyone came here knowing that tobacco, which is in the upper right, was a leading cause of things you could do to avoid cancer in your lifetime. The damaged cells force them to repair themselves and give errors of DNA replication, which is what causes cancer as a somatic disease. What you didn't know is the biggest culprit in Westchester County for cancer is what you just ate. it's diet, it's obesity, it's a sedentary lifestyle that today and for the last decade has been the leading cause of the high incidence of cancer that's been retained over the last 20 years as our ability to cure it has gotten better. We didn't even know this existed 10 years ago. The first time at Memorial, we proposed a program to look at whether obesity had a role in cancer. We were laughed out of the face by the NCI. This is the NCI's own data from 2 years ago. It is today the leading cause of preventable cancer in America, both male and female. And it's not the diet you've heard about that made your cardiovascular health. It's why our former mayor in New York City tried to get ahead of the big gulp and the big soft drinks. It's carbohydrates, simple sugar carbohydrates that are the driver of that. Second cause is the meal size that Americans have. We still don't fundamentally know why, but we need better obesity programs because one of the big bad outcomes of obesity, beyond all the other things that you've heard from the great medical centers here, is that in fact it's the big driver of the increase in cancer risk of Americans. And it's worse if you just look around the population here in Westchester, we're getting a little wider all the time. So we need a partnership with the other great accountable care organizations to get ahead of this. We don't do obesity, we don't do diabetes, we have a great exercise program for our cancer patients, but exercise does play a role, we don't understand that. So all the other things pale in compared to those two risks, obesity and tobacco. One of the most exciting things that came out of the sequencing is that many cancers are a lot different than when the DNA mom and dad gave you. You acquired in that cancer a lot of things that made that cell different than the one you should have made if you just listened to mom and dad. They told you that a long time ago as a kid, but it turns out it's true. That has been the extraordinary opportunity. We've had an immunotherapy program, how to help patients harness their immune system. It's always been a theoretical possibility since we started the program in 1890. We had many iterations that sort of helped, but didn't really work, but always gave a glimmer of a hope that there would be a way to harness the immune system. We now know from that sequencing how to identify the patient. The two big breakthroughs that you've been hearing about, this thing called checkpoint blockade, which was reduced to practice at Memorial Sloan Kettering for the world by Jim Allison when he was with us, and then more recently CAR T cells, are directed at tumors that are so different, because we can identify DNA from mom and dad, that your immune system will be taught to recognize them as foreign and potentially cure you. Today, about 20 to 25% of all cancer patients that we see receive immunotherapy. And the good news is 4 of the checkpoint blockade measures are now FDA approved, so they're available without a clinical trial. And in the next month, we'll have 2 forms of CAR, what's called CAR T cells, or genetically modified patients' own T cells, so they're taught to fight off the mutations that are in the cancer. Now, one, we're really pleased is going to be available in every hospital in Westchester. There are some problems. This is new complications for neonatal seed. It's like having a rheumatologist give immunology, and we've had 10 years of experience, so we still believe there are clinical trials to extend the reach of immunotherapy. But these new genetically modified T cells are reprogrammed by genetic means, the patient's own T cells, to fight their cancer. The FDA has already announced it's only going to be available for at least the first year or 2 in only 10 hospitals in America. And we're going to be one of them because one of our scientists pioneered this as a basic idea. And so it will be available here in Westchester, but unfortunately, and I don't like telling this to my colleagues in the other healthcare centers, only if you're a patient at Memorial Sloan Kettering. Because in fact, the FDA has mandated these are such a complex therapy that they'll do that. But our expectation is within 10 years, every hospital will be able to practice these kinds of therapies going forward. So again, our role in Westchester is to be the innovation leader. But we ultimately won't succeed unless every hospital in this place can provide it. So how do we do this? Two things about our value mission for Westchester County is that we have never wanted to take more than 15 to 20% of any population in the greater New York area. Not our goal. There are great other hospitals that we partner with. But we need to see 15 to 20% of patients so that we can provide the studies we do, the clinical trials, the 800 that I've told you about writ large, 300 of them available here in Westchester, to figure out how to improve, because patients want a better treatment, a better therapy. 70% of the patients put on clinical trials in the greater New York area are treated at Memorial Sloan Kettering. That's our role. When it's reduced to practice, really your patients can go to many of the other major medical centers. We're happy to give second opinions. We do treat some patients with those more easily controlled cancers. Because we have a major training mission, we teach over 1,700 physicians high-quality cancer care that they then go out and practice every year. So we have a training mission as part of it. We have trainees, even our Westchester, who are from other medical centers learning how the best process of cancer care. But the opportunity to have clinical trials right in your backyard where you don't have to come into Manhattan is why we decided to put a newer facility that could support those kind of activities here in Westchester. And then the final reason, which is why we think we, unfortunately, will never go away, 50% of cancer, because there's 400 different diseases that make up cancer, are rare cancers. They're cancers that even a medical oncologist, full-time practices taking care of cancer patients, might not ever see in their entire lifetime. So I'm going to give you one example of that. If I could get this thing to go forward, I'll give you one example. So this is just to make up that point. 50% of the cancers are the common ones: breast cancer, colon cancer, prostate cancer, lung cancer. But the other 400 make up that remaining 500. About 10 that make up the bulk of 50%, and then the other 390 make up those others. The reason we believe we will always exist, certainly in Manhattan, but we want to be in the entire greater New York area, is for that patient with a rare cancer where there isn't the ability to aggregate in any of the accountable care organizations enough expertise to give optimal treatment for that relatively rare disease. So I'll give you the example. This is the one the President of the United States, President Obama, when he announced the precision medicine, and never used himself. And that's this young girl, Elena Simon. And Elena allows this to be used. She's currently a junior in college. When she was 13, she came down with a cancer called fibrolamellar carcinoma of the liver. Now, I will be completely honest. I've been a medical oncologist for 40 years. Up until 2012, I had never heard of the disease, let alone seen a patient. And the only reason I heard of the disease, I got a call from somebody I won't name here in Westchester who said, do you at Memorial, I have a family member not living in New York, living far away, who's come down with this diagnosis. Do you in Memorial able to take care of a patient like that? And I said, well, we have a lot of liver cancer experts, but I've never heard of this particular disease and this particular subtype, but I'll find out and I'll get back to you. And I called up, Rich Barakat knows this story here as one of our leading surgeons, and I called the head of our liver cancer program and said, do we have anybody, do we ever see this, what is this fibrolamellar carcinoma? He said, what are you talking about? Every Wednesday afternoon, we have a clinic for patients with fibrolamellar carcinoma. There are only 200 to 400 cases a year in the entire country out of 300 plus million people of this cancer. It always happens at puberty. It's more common in women than in men. I learned a lot about it since 2012, so I'm better about it, okay? And it's one of the most satisfying or one of the most disappointing cancers that we care for at Memorial Sloan Kettering, because it just spreads locally in the liver and slowly but surely destroys the liver. If we find it early enough when they're referred to us, our surgeons are good enough at taking up to 80% of the liver out to cure a patient, and you can recover from having 80%. But if they can't get it out without leaving you some liver, we do it with a liver transplant occasionally, the patient always dies because the tumor just grows inexorably. So it's horrible. Elena was one of the lucky ones. She got half her liver taken out by the team, completely cured. She got interested in science, had been interested in science, interested in how this could have been and why she was lucky or unlucky. So she came back and worked in our lead surgeon's laboratory the summer before she went to college. She decided that she'd heard about this DNA sequencing we were doing, but we were never going to see, we see 1 or 2 new patients a year, really, from our own catchment area. And we get a few referrals from the greater 150 miles from Hartford and from northeastern Pennsylvania, but we never aggregated enough people. And she said, I know about this thing called social media. So she started a social media campaign right out of the lab and asked every patient in the country through social media, would they donate their DNA so we could figure out if there was a common abnormality that caused this rare cancer? Turns out every single patient has exactly the same mutation. Turns out we had in our research laboratories 2 drugs that treated that abnormality. Today, we run 2 clinical trials for those 2 drugs to compare them. Every patient in the country receives that. Those are good medicines because they're oral. So we can actually, they have to come once to enter the trial at Memorial, but then they get all their care back. So you could go to Westchester if you had this sadly rare cancer and actually had to do this. When President Obama decided he wanted to talk about the importance of precision medicine and what sequencing the genome benefited for people, he heard Elena's story and invited her. In fact, this is her introducing him so he could announce the national effort on precision medicine. There are 390 of these kinds of cancers. This is one of the rarest, but this is something we do. We have 1,200 physicians who only do oncology. So that being said, the counterpart for the business leaders is, somebody has heart disease, do not send them to us. Send them to one of the other great medical centers. Because this belief of American specialization can make a difference, but we have to do it in partnership with the other, because patients get all the other diseases. We have to have our partners working in concert. And that's why it's great to be part of a community that has such great health care, to try and advance that through innovation. And that's why we believe we built the center I'm about to show you. I'm not doing very well with this. So this is actually an artist schematic. It actually looks like this. They wanted the slides earlier that I could get the staff to import a picture. But if you go, it looks exactly like this. This is our facility in West Harrison. As I said, we have 300 clinical trials. It's centrally located in Westchester in a way that patients can come for second opinions or other things. We're here to add to improving the healthcare quality of people that live in Westchester, work in Westchester, have their families in Westchester. We're not here to compete, but we have been here for 23 years, and this is our modern iteration that allows us to provide the latest therapy advances. These are the therapy advances that become available by coming to a clinic. We have a big program in robotic surgery to decrease the side effects of surgical complications. Still, most patients are going to enter with surgery. We are in the West Harrison side, the ability to do interventional radiology, so we avoid many of the complications of surgery for biopsy and diagnosis. One of the most important things we add to a community is getting the diagnosis right. When patients are shipped from afar, from outside the greater New York area, we find 22% of the time the diagnosis they were given when they were told they had cancer was inaccurate and would have led to a wrong treatment. Well, you could say that's just us and arrogant. MD Anderson, which serves the Texas community, it's a public cancer hospital, just published their statistics, came to exactly the same number. That's because there's an evolving knowledge. I'm not trying to be critical of other healthcare professors. Cancer is much more complex than any of us imagined 100 years ago. I've talked about precision medicine. We are partnering with 2 of the big health centers here, both Mount Sinai and Montefiore, to open New York's only proton therapy center. It'll be opened in a year from now. We do, for our own patients, have a center that we participate in New Jersey, so we can give people in Westchester opportunity. Proton therapy is an advanced form of radiation that has more limited side effects. It's critical for kids with cancer. It's critical for people that have cancers near their spine or their brain. And so there's going to be one New York site, and we've partnered with 2 of the healthcare centers here to have one common facility we'll run together to provide that as an alternative. And then immunotherapy and cell therapy are the real advances. We expect within 10 years, 2 facts to tell you about, because we look out into the future, we expect 50% of patients to have either immunotherapy or cell-based therapy as their therapy of choice starting 10 years from now. With that to be curative intent, a wide variety of things that we have never seen cured before are being cured with immunotherapy. And secondarily, we are expecting that, in fact, we're predicting 75 to 80% of the patients we treat will never spend a day in the hospital. They'll receive all of their surgery as an outpatient basis, all of their chemotherapy, all their radiation. If they don't have a serious side effect, they will go through the entire cancer care without ever spending any time in a hospital. We've learned that actually accelerates their recovery and accelerates their ability to get back to work, back to taking care of their families. And so those are our aspirational goals, and we're going to try and achieve them at the facility. And then the one thing we've learned that is really important, and all the other hospital centers are doing the same thing, care has to be coordinated. You can't go to a surgeon one place, a radiation oncologist over here, a medical oncologist who only works on Wednesdays. You've got to have a whole care team. So we have been pioneering a model where you will have a point lead physician, as we've all come to expect in American healthcare. But everyone is assigned a team at Memorial Sloan Kettering when they come to us and ask to give advice or treatment. They get a whole team, and the team is optimized and rewarded not so that each person uses their skills, but we make the best use of the combined skills in that for that specific patient and that specific diagnosis. That is why we continue to have among the best outcomes in cancer care, even for the routine cares. A surgeon doesn't get rewarded if they do surgery. They get rewarded whether the patient does well, even if they didn't do surgery because it wasn't indicated. And so with that, I think I just want to open this up for any questions you have. I appreciate it. I went a couple of minutes over, but you've been a very attentive audience, and I'm happy to take any questions from the audience.
You mentioned earlier that, I'm right here.
Gotcha. Sorry. You're right in the light, so I got you.
You mentioned earlier that diet, exercise, sedentary lifestyle contributes a lot to cancer. Do you find that or have you ever had a program where you used diet to treat cancer, absence of medicine?
So we have a variety of programs looking at how diet influences the outcome of treatment with cancer. From very complex things with things like hyperalimentation, where we feed patients extra nutrients. We are one of the few hospitals that has never outsourced our food service. We actually carry 2 executive chefs on the strategy because we do think caloric intake helps patients improve. So we have trials on that of just the acute support of nutrition during chemotherapy and what it does for people. Increasingly, though, we have a variety. We, whether it's good or bad, have now 1 million living patients that we have treated. You know about this for cardiovascular disease. If you've had one heart attack, you're at higher risk of having a second. Things that you're at risk for, you have higher. So the most identifiable population that has a higher risk of cancer than others is patients that have survived one cancer. And so we are doing a variety of nutritional intervention trials in that population to try and see if it helps improve or decrease their subsequent incidence of cancer as we follow them as cancer survivors. We don't have many programs in nutritional health for the general population that has never had cancer. That we need to partner with the great other medical centers that we have here. But we are doing a variety of research studies to try and give advice on that. And there are 2 lessons that we're very comfortable with right now. One is reducing caloric intake definitely reduces cancer risk. So if you could live your life at 10% lower body weight than what American calls normal, you would have a significantly lower cancer risk. Most Americans can't do that, but the data is absolutely clear that reduced caloric intake across the board, doesn't matter what the calories are. So you're taking less than what the American nutritional guidelines are, you'll have a reduced cancer risk. So that's one insight. The other is there is no question additive on that is the amount of simple sugar in your diet increases your risk of cancer, but we fundamentally don't know exactly why. There are 2 major theories that are being investigated in our research lab and elsewhere in the country. But right now, we know that simple sugars increase the risk, but we don't know why. The oddity that came out of all this is fat doesn't matter. We did hundreds of studies as a cancer community over the 50s and 60s to see whether or not you reduced fat or, better fat diets would improve. Every study so far has shown that fat in your diet is not an important part of the cancer problem, except as it contributes to total caloric intake, if that makes sense. That's not true for cardiovascular health, and that's why yesterday I gave a talk at a lunch just like this, but it was formed by the American Heart Association to talk about exactly those issues. So we had the leaders of the community talking about exactly that issue you're talking about. So that's at the front edge, so obesity is the driver, simple sugars is the second cause. That's about what we've learned to date, and we are building various programs. Next question. Yeah.
Thank you for your presentation. You are expanding the brand, I guess, down as far as exit 14 in New Jersey,
Yeah.
Longueville, and Westchester, and now. What's the plan, and how will you take Memorial Sloan Kettering across, I guess, the region and what the region is?
Yeah. So I should explain that for the healthcare leaders that are here. We don't really see it. I have to say, I don't see it as expanding the brand. We have always. When I was an intern, I had the privilege of rolling the first patients into the Dana-Farber. I remember telling the patients that we rolled them over the wall from through the Brigham and Women's Hospital, the Children's Hospital, over to the care unit at the Dana-Farber, that we're going to build a cancer center as good as Memorial Sloan Kettering. So you'll have hope, and you'll not have to leave New England. So Memorial, when I was an intern and resident, taught everybody in Mid-Atlantic who wanted to have a chance at cancer there. And that was a long time ago. A lot of different therapies have gone by. Part of the problem is that cancer has become a more complex disease as we learn this molecular basis. These precision medicines, you don't just treat somebody with lung cancer, they also have to have, I'm sorry for the names, an ALK mutation to get one of the newest drugs that's available at Westchester. That's only 5% of people with lung cancer. So we need to have a wider net to find enough patients to do an informative clinical trial to say this makes a difference, doesn't work. And patients expect a different outcome today. Every patient I saw as an inpatient at Brigham and Women's Hospital, one of Harvard's teaching hospitals, when I was an intern, that had cancer and was on the inpatient basis died that year of their cancer. Nobody thinks about that now. Everybody has seen the hope and the opportunity of being cured of cancer. In all the great medical centers, there's real hope and opportunity from all of the advances, some of which I just summarized. And so right now, patients want a therapy that can be delivered closer to home. They want to be able to be involved in a trial where they can still get to their school play, or they can get to the soccer game, or they can get to work for that important meeting. And that means we have to be out in the community. The third reason is just what I told you. Cancer is an outpatient disease now. In 1990, 90% of the care that Memorial Sloan Kettering gave was in our inpatient hospital in Manhattan. Today, 10% of our care is there. 90% of our care is on an outpatient basis. Now, 50% of that's still in Manhattan, but they're in our 4 treatment centers in Manhattan and in Brooklyn. But the remaining has to be out where people live. And so we really see the facility we have in Westchester as the expansion of what we pioneered with Dr. Safian here in Phelps in Westchester 23 years ago. This is just the more modern iteration of that. And now it really is designed for full. It doesn't have to be attached to a hospital like Phelps. It's a freestanding facility. So we don't have an expansion plan beyond that. We want to be within a half hour of everyone that lives in the greater New York. So nobody has to commute during the daytime for more than half an hour and be able to get the same standard of care, whether they come to our main hospital or they come to an outpatient center. And that allows them to be comfortable that they can live their lives. Cancer therapy, unfortunately, particularly on clinical trials, takes longer to deliver than if you weren't on a clinical trial. That's the negative. The other is you get a better outcome. Other questions?
Yeah, I had a question. I wonder what you're learning about the impact of chemicals, pesticides, and plastics.
Yeah, it's a really good question. So one of the things that's come out of all this sequencing effort that I've told you, that we don't get reimbursed for at all right now, and we're hoping to get the government to reimburse us, you can start to see molecular signatures and the mutations that our cells have as we repair our cells that are a result of certain clear chemical insults. So there's a clear signature from the carcinogens of tobacco in lung cancer patients. So we can, in fact, there's a great story from our colleagues in England that we partner with on a lot of the sequencing, which is the Wellcome Trust, who do a big sequencing effort for the British National Polling. The signature is the same, because tobacco smoke is what it is. They actually found one human being who said, I have never smoked, who had exactly the same signature. They discovered a mutation in him that taught us a whole bunch about how DNA repair that we hadn't understood before. But he's the exception. Everybody else was actually a big smoker. We have the same kind of molecular lesion for all the skin cancers. And so that's what UV light does to us. So you can see that the specific mutations that are caused by UV light can now be diagnosed. And so we know the melanomas that you've heard that have so expanded, particularly in the US population. It's one of the reasons why Australia has adopted a lot of this stuff. There are definitely now several signatures that look like they're based on common exposures to something that's in the industrial world, whatever that means. But we don't have a clue of what's causing them right now. And so there's a big effort to try and say, are there some remaining things we're exposing ourselves to unneedly? But now it's a molecular game rather than epidemiology. You're not looking for a dump. You're looking for what's the common feature in the medical record of those people that have that kind of mutation. We're hoping that there will be a couple more. But what I will tell you, it's not a big group. Sun's a big one. Tobacco's a big one. There is a common lesion of the way we detoxify things that we eat in the world that's in your bladder, so it's associated with bladder cancer, because we tend to protect ourselves through the liver and through our urine by peeing things out. So there is a signature there, but there seems to be a couple more things that are more common in the industrial world, so you don't see these mutations in a population in the developing world, that may be identifying certain classes of carcinogens that we hadn't exacted. But it's not a big group. So the good news is there's nothing like tobacco. Obesity is this one signature I told you about that people are interested in. But we're not going to have another amazing discovery. And this is for only the older people. There is no benzene in paint. Benzene, all paints were made with benzene as the thinner up until 1940. And then epidemiology told us it caused bladder cancer. And so there is no benzene in paint anymore. It's a great story of good public health initiatives that led to the elimination of a disease. And so that we now have much better paint thinners and we don't see bladder cancer. There isn't going to be a story like that. It's not going to be tongue cancer in the radium workers, another famous story of epidemiology, of all the women that used to paint radium dials on our watches. Remember when we were kids and you had a radium dial you could watch? They all came down with tongue cancer, and that was associated with the radioactivity and proven. We don't have a lot like that. I know the population's worried about that. There will be some other things, but our bet is it's not one thing. It's the common exposures we have to a variety of industrial things. The real surprise for all of us is the big driver is obesity and the sedentary lifestyle, type 2 diabetes. Final thing, at least to finish that story off, exercise clearly contributes to a prevention from cancer, but we don't understand why. And it's different from just the obesity. There's a benefit from exercise. Last year, the Nobel Prize was for discovery of a biologic process by which all our cells take out the waste that accumulates when you do anything, called autophagy. And the current theory is that the exercise activates that waste removal from our body, and that's the protection, but it's not been proven. So I just want to tell you there are interesting ideas. This is a time of innovation in cancer, and that's one of the big new excitements. And I'll bet that's a bigger insight than that there's another carcinogen. Sorry, that was a long answer to your question.
I think I'm
Yes.
next. Thanks. The federal government is in the process of limiting their financial liability for healthcare in a number of ways. One of them is reducing funding for the National Institute for Health. So what are your thoughts on pushing back against that, and how important is NIH funding to your organization?
Okay, I'm going to do a shorthand very quickly because I'm about to be dragged. Bill's going to drag me off, and you guys need to get back to work and do stuff. America's a service economy today, which means we should have a balance of every industry versus how much is consumed. We should be self-contained. Right now, 17.89% of GDP goes to healthcare. It's dragging down the economy. Many business leaders are worried about how much they're having to pay for their workforce for health insurance. The only industry left, I'm going to argue, somebody will argue about social media with me, that has traditionally been led by America, continues to be led by America, and which we're admired throughout the world for in every venue I get to represent Memorial Sloan Kettering, is healthcare. I get to go represent us in many of the emerging nations to give talks like this, and they always drag me to an OR. And everyone in the OR tells me the period of time they trained in the US and learned what the skills that they now practice wherever they are. They show me the equipment that was made by a manufacturer, one of the global ones where America's part of the innovation partner. They tell us that the drugs that they can adopt of the kind that I've told you about. When you total it up, and part of the problem is that the healthcare community is two communities that's represented here. It's innovation, it's biomedical products, it's drugs, and it's care to Americans in hospitals and in great accountable care organizations. 20% of Americans are employed by biomedicine. We're a balanced economy in healthcare. And we're actually doing pretty well on that. Yes, we do need to figure out how not to adopt every little toy except where it's needed. So I give you the example here, is proton therapy really does matter for a few cancer patients, but we've got, in certain parts of America, these things cost to build a proton therapy facility, you need a football field size. The building's a football field, because that's the cyclotron that generates the proton therapy, is the size of about half of this room. It has to be delivered in something that's at least a football in size, costs $300 million to build. New York State, because we are a certificate of need state, did an estimate of how many patients would benefit unequivocally from the scientific proof that this is a better therapy. It's between 800 and 1,200 patients a year. You only need one in New York. They did the right job. They said we had to partner. We started with 5 hospitals, the 5 major hospital systems. There are 2 dropped out because they think there's going to be a cheaper way to build it someday, and they'd like to have their own. But this is the right dispersal of healthcare. The 3 of us, Montefiore and Mount Sinai Continuum, and us are a partner. And we will be able to treat all 800 of those people and continue to do some clinical trials to see if it can be extended. And you don't need to have 6 of these in New York. And so we do have to worry about cost containment for healthcare, but it is still a meaningful export industry for America. It is still something we're admired from. And yes, Americans don't have the longest longevity, but I just told you, we're also the most obese nation, and we still smoke despite 55 years of being told not to. And we are incredible optimists, so we want the best care as quickly as possible, so there are some other drivers. But healthcare is not broken in this country. And somebody living in Westchester County with the collective expertise here gets phenomenal healthcare care. And I think we're all in partnership over that. So it's a privilege to be here. Thank you very much for your attention, and get out of here.